Our next speaker is Scott Shannon. Scott has elaborated a holistic and integrative perspective in psychiatry for over 2 decades. In 2010, he founded the country's largest and most comprehensive integrative mental health clinic, Wholeness Center, in Fort Collins, Colorado. His current passion is training psychiatrists in the new paradigm of mental health. Scott Shannon.
Well, happy to be here today.
Oops.
Go. Now I'm plugged in. All right. Well, I want to thank MAPS and Bia Labate for inviting me to present today, and it's my pleasure. I'm currently involved with MAPS as a site PI for the MDMA study in severe PTSD in Fort Collins. And our clinic, which is an integrative holistic clinic, has been working with CBD for probably 4 years now. And we've got a lot of experience, and I'm going to be talking with you about that today. And this really is sort of a nuts and bolts, ground level talk. A little bit about the background of cannabidiol and what it's about in terms of its relation to cannabis and mental health. A little bit about its physiology, and then talking about our clinical experience. And want to leave some time for some dialogue with the audience, because this is really clinical stuff, and we want to make it as practical as possible. So I've written 4 professional books that I receive royalty for, and that's my only connections in this field. Have not been paid by any cannabis-related manufacturer or CBD manufacturer. So as I mentioned, just briefly talk about the history of cannabis, cannabidiol, and look at a little bit at the recent research, and then we'll get into sort of our case series. We've had 2 publications on this so far, and the publication reflecting the data I'm presenting today is about to be submitted for publication as well. So Colorado is sort of the green frontier, if you will, and every time I tell someone I'm from Colorado, I usually get a cannabis joke in some way. So that's just part of what you get. And I think right now the state is raising between $100 and $200 million a year from cannabis, so I think it's just a matter of time before other states in the country follow suit because problems balancing their budget. And we know that cannabis has been in use a long, long time. This is sort of an ancient sculpture going back thousands of years in Thailand. And cannabis is possibly the first cultivated plant in history. So we know it goes back at least probably 4,000 to 6,000 years in terms of its cultivation, either for hemp and fiber or for other reasons. And this has been in use sort of throughout Asia, Southeast Asia, and then segueing throughout the Middle East even. And this is from a medicinal, medieval medicinal about, quote, garden hemp. So it's been known for a long time, it's been in use, and it certainly has a range of different effects and possibilities. The medicinal uses go back almost equally as far, going back probably 3,500 years in the Chinese pharmacopoeia. And I'm not going to go over all these, but I think one of the most interesting ones is in China. They recommend cannabis for 100 things, including gout, arthritis, and absent-mindedness. I thought that was the cause of absent-mindedness, not the cure for it. This is just a little look at the chemistry. Now, interestingly, chemically, THC and CBD can be interrelated, but that does not happen in the body, or CBD would have gathered a lot more interest than this in the past, I think. So interesting from an evolutionary perspective, we have a whole cannabinoid system in the body that goes back in terms of phylogeny, just down to primitive animals with nerve networks such as the hydra. So it's really pervasive throughout the animal world. And anandamide, which comes from the word Sanskrit meaning bliss, is a mediator for this endocannabinoid system. And I'll talk a little bit about how CBD actually relates to anandamide. It's not a direct relationship. So we know there are 2 different types of CBD receptors, CB receptors in the endocannabinoid system in the body. The first one is found in the brain, and it's found through a range of different areas in the brain. And the second is more peripherally located, and that tends to be more related to the immune system. So anandamide is this mediator of the central endocannabinoid system in the body. And what the interesting relationship is that there's an arachidonic acid eicosanoid precursor that's related to the endocannabinoid system that CBD actually relates to, alters the state of the FAADH. And then what happens is that in turn relates to the breakdown of anandamide, which in turn triggers the endocannabinoid system. So CBD has an indirect relationship to the amount of anandamide in the system, and that in turn triggers the endocannabinoid system. So this is from a hemp field in Europe, and I'm happy to say that we're now cultivating more hemp in the US, and actually I found out that fairly close to where I am and in Fort Collins, they're now starting to produce hemp, and we'll be growing hundreds of acres of hemp as it sort of rolls out across the state. So soon we'll see signs like this in the US as well. Now, one of the things about cannabidiol is that it has had this explosion of interest in the last number of years. And if you can see this graph, this is when topical areas were first identified, and then the graph also sort of highlights the amount of publications. So we're up to about 300 publications per year now on CBD. And what's interesting you can see is that the first work started with epilepsy in the 70s, drug abuse, anxiety, psychosis, Huntington's, neuroprotection, MS, Alzheimer's, Parkinson's, depression, and ALS. So it's very difficult to stay current with this field because it's just increasing geometrically. And I think it's increasing geometrically because people are realizing that this has a profound, pervasive effect in biological systems, and not only in terms of medical interventions such as pain, but also for psychiatric interventions such as anxiety, psychosis, and probably even trauma. So CBD is one of the cannabinoids found in cannabis. It's one of 85 or more that are found, but it's one of the ones that's either the second or third most prevalent in terms of a chemical breakdown of cannabis itself. It is not intoxicating. I sometimes say that it's not psychologically active, but that's not actually accurate because it is psychologically active. It's just not intoxicating. Now, one of the interesting things you find in the plant kingdom, and this is really in the plant tracks, we want to talk about this a little bit, is often in plants we find that they contain complements or antagonistic chemical compounds that give different effects. For example, in the tea plant, we have caffeine and we have L-theanine, and these tend to have a counterbalancing effect. They both tend to improve focus, but one tends to increase anxiety and the other tends to decrease anxiety. So I tell people that CBD and THC have that antagonistic effect, and we'll talk a little bit about that. Actually, this is not accurate here. It can be sourced or legal in 50 states. I'm not going to pretend to know what's legal or not because this is very confusing. I will say that it's available in 49 states. I know that Texas has specifically outlawed CDB. And I don't understand why that is, but they've taken it on themselves to do that. In terms of the half-life for cannabidiol, I've seen a range of different things in publication, and I've not seen one that I will fully hang my hat on, but the range is somewhere between 21 hours and 48 hours. So it's a fairly long half-life. And people also talk about an inverted U-shaped dose curve. And what that means is that you don't see much effect at low doses, and then you see a significant effect at moderate doses, and then the effect seems to fall off. And that has been consistent with our experience as well, is that you have to work with people individually to find the right dose. This I'm not going to go into. This may bring back flashbacks from your biochemistry class in college. But this is some understanding of what cannabidiol can do. And some of the things we see that are of great interest is it increases neurogenesis. And right now, neurogenesis is felt to be one of the factors that is responsible for depression. When you have a fall off in the production of new neurons in the hippocampus, then oftentimes what you have is an onset of depression. And if people are not making new neurons, they may be indeed depressed. So this looks like it supports that. It also decreases the apoptosis of neurons, decreased neuronal damage and cell death. So it does look like it's neuroprotective in terms of neurodegenerative disease. So in terms of mechanisms, we don't really have the exact mechanisms, but as I alluded to before, we know that in a range of neuronal centers within the brain, it produces the opposite effect of THC in a number of these key regions. So for example, the striatum, the anterior cingulate, prefrontal cortex, amygdala, most importantly perhaps, and the cerebellum. So one of the reasons we're seeing, I think, such benefit of MDMA in treating trauma is its ability to quiet down the amygdala, the fear center in the brain. And CBD looks like it does that as well. So CBD oil, it's neuroprotective, antioxidant, anti-inflammatory. So there's a lot of talk and its value in treating pain issues, treating epilepsy, treating even neurodegenerative illnesses. So there's a range of clinical trials. I'll go through and talk a little bit about them in short work. So here's one in anxiety. This is a review article just published in the last couple years. And this article looked at all the existing data, clinical data, preclinical data, and even epidemiological data. And what they found is that it strongly supports CBD as a treatment for general anxiety disorder, panic, social anxiety disorder, OCD, and PTSD acutely. We know very little about chronic dosing. We're really out on the frontier of this as a treatment in psychiatry and in mental health in general. And I think we really want more clinical studies. And so that's one of the motivators for me to get involved in this and try to put more publications out there to support its, I think, informed use in the public. Here's an interesting study looking at social anxiety. And that's really one of the areas that we thought the CBD really significantly helped people in, is with the social aspect of anxiety. So this is a randomized controlled trial of 24 patients, 24 controls. Now they got 600 milligrams of CBD. That's a lot of CBD, and CBD at those kind of doses is very expensive. But they were given a public speaking test, and lo and behold, what they found is the people that got the CBD had levels of anxiety consistent with those found in the normal population. So what are the basis of this? This is a study looking at brain imaging, and what they found is decreased regional cerebral blood flow in the left parahippocampal, hippocampal, and inferior temporal gyruses, and increased blood flow in the right posterior cingulate. So these are consistent with something that would have an anxiolytic effect and help to reduce anxiety. So we know that the sort of neuroimaging and neurophysiology pathways of CBD make sense for it to be an anxiolytic. Some studies with sleep. Now the studies with sleep are not as good and not as significant as some of the other studies. So this is an interesting study that took 8 people and they did a 4-way crossover. So they got to try 4 different products. One had 15 milligrams of THC, which is a moderate dose. One had 5 milligrams of THC and 5 of CBD, sort of low dose of each. Another had 15 and 15, and then they had the placebo. And what they found is that some of the combination products decrease stage 3 sleep, which is probably not a good thing. They increased sleepiness the next day, and they saw changes in mood. The THC one alone had no change in sleep. And in general, we have not been using any combination products at our clinic. We're recommending CBD oil, which is really hemp-derived and does not have THC in it. And as a child and adolescent psychiatrist, I see a lot of kids and teens, and I really don't like the idea of prescribing THC or cannabis for them because we're concerned that it may disrupt and distort the neurodevelopmental trajectory of the brain. So, to my mind, at this point, not a good idea. Now, interesting study. This one looked at psychosis and paranoia. And this was a study out of Vancouver comparing CBD in high doses to an atypical antipsychotic. So this is sort of the state of the art for treating psychosis and schizophrenia at this point. And this study looked at a comparison, very high dose CBD, 800 milligrams a day, compared to an atypical antipsychotic, one that is not available in the US, but is considered to be a mainstream antipsychotic. And they found that both groups were significantly improved. And these were chronically difficult patients who had been diagnosed with schizophrenia. They'd not been able to achieve full treatment remission. As you might expect, the CBD group had many fewer side effects. Atypical antipsychotics tend to be sort of metabolic toxins. I'm not a fan of them. I don't like to prescribe them at all. And this gives us an idea that we may have options to look outside the realm of atypical antipsychotics. And this is just a graph showing some separation between the CBD and actually improved outcomes compared, at least in graph-wise. They were both significant in terms of outcomes for the patients diagnosed with schizophrenia. So our case series, segueing into that, we had basically the way that the research was set up was we had ongoing clinical practice at our office where we are using CBD very widely. We have 7 prescribers. We have now 8,000 patients at our clinic. It's a very large clinic. We integrate naturopaths, acupuncturists, biofeedback, neurofeedback. And I think one of the founding philosophies and goals of our clinic is try to reduce the use of psychiatric medication and try to find true healing for people, getting to sort of underlying mechanisms and trying to help support people's full recovery and not just the suppression of symptoms. So it's a different approach to psychiatry, what we call integrative holistic psychiatry, and that's something I've been involved in for 30 years. So what we did is we went back, got IRB approval to retrospectively mine the data from the patients in our clinic who'd been prescribed CBD. So this was really not a prospective study going forward, but just a look at our observations, our experience with our patients, a variety of different practitioners, a variety of different diagnoses. What we found is that sleep and anxiety were the 2 most common, so we pulled 136 charts of patients that had CBD with a sleep or anxiety diagnosis. 27 pediatric patients, and 59 patients had 3 months or more of data. I think there were 43 patients that had just had 1 month prescribed. So with that as caveats, we realize that this is observational data and that each month that goes along, we're going to have fewer and fewer people that are still in the study. So the screens we used were the Hamilton Anxiety Scale in the adults and the Pittsburgh Sleep Quality Index. These are both standardized scales that are available in the public domain. And then for children, we used the SCARED, which is the screen for childhood anxiety-related disorders, and the Sleep Disturbance Scale for children. These were given monthly, and then the data was mined from that. The dose range ranged between 3 milligrams and 175 milligrams. The most common was a 125 milligram capsule per day. Overall, we found this was very well tolerated. We had, in the 136 people, I think only a couple people stopped it that they told us because of side effects. Mostly fatigue. That was the most common one that we saw. We did have one patient of mine, a patient with developmental disabilities, who, when he was put on the CBD, became sexually inappropriate. We took him off, it stopped. It really helped his anxiety, so we put it back on him. He became sexually inappropriate. We took him off, and we realized that his anxiety was actually keeping his sexual impulses in check, and when he became less anxious, he became less appropriate. So we had to leave him anxious, unfortunately. But it worked, at least for what we were trying to treat. So we saw many people, particularly with anxiety, that had a dramatic response within 1 week. Generally, we saw a response, people were going to respond within a few days, usually 3 to 5 to 7 days. With that long half-life, you tend to expect that. We used it on a wide range of comorbidities. Some of these people were on psychiatric medication, some were not. We saw a range of things. And as I mentioned, the wide range. Now, one of the interesting things I found in my practice is that there was little pushback. Doctor, I don't want to be involved with cannabis, or that it's that wacky tobacco, I'm not going near that. We had parents of 5-year-olds to elderly patients who said, sounds good to me, let's try it. And really, I think people's motivation is really significant, at least in our clinic, significantly strong, that they'd like to avoid psychiatric medications if at all possible. So here's what we saw in the childhood anxiety. This is only 5 patients, so just keep that in mind. And I think on the adult anxiety, you'll see sort of similar scale. Here's adult anxiety. So what you can see is the Hamilton Anxiety Scale. Over 17 is considered moderate to severe. So 25 is the cutoff between moderate to severe. So these people had significant anxiety. And what you see is that by 1 month, it went down significantly and held and stayed down throughout the time course. By the time we get out to, say, 6, 7, 8, 9 months, we have maybe only 8 to 10 people left in the original sample. Adult sleep, it's hard to make sense of this until you realize that once we get out past 6 months, we only have 1 or 2 patients out here, so you really have to ignore this data. Now, one of the interesting things we found is that when we gave it for sleep, people told us that they were sleeping better, but when we actually did the sleep surveys, it didn't look like that much difference. Our hypotheses, working hypotheses, is that people were less anxious about their sleep, and so they were ruminating about it less concerned about it, but actually in terms of the time they slept, not that much different. So our impressions, best indications were social anxiety, PTSD, nightmares. We had quite a few people that within a day or two of being put on CBD, their chronic nightmares went completely away. We had that, and it was really a very significant finding. Sleep, middle insomnia seemed better than initial insomnia, generalized anxiety, and cannabis withdrawal. We published one paper on cannabis withdrawal, and if you think about the mechanism and the makeup of cannabis, it makes perfect sense that CBD would be a very appropriate intervention for someone who's withdrawing from cannabis electively or non-electively. The dosing is fairly easy, 25 milligrams, 15 to 25 milligrams a day sort of makes sense. And I think it's sort of our target. We did not see much sedation. We did not see much appetite change. And the cost is really, it's a significant factor. 25 milligrams a day on today's marketplace is probably $50 to $70. Here's what we see with cannabis withdrawal. The pattern is anger, irritability, decreased appetite, weight loss, night sweats, nervousness, sleep disturbances. For a number of years, I've worked as medical director of a residential transitional living program for young adults 18 to 25, and over half of them were having cannabis issues, and we saw a lot of cannabis withdrawal. We actually saw a lot of high-dose cannabis toxicity, and one of the hallmarks of that is anxiety that's through the roof. And one of the interesting things, they think they're treating their anxiety by continuing to smoke cannabis, but once we get them to stop smoking cannabis, somewhere around 2 weeks, their anxiety melts away and they go back to their pre-morbid state. And we saw that again and again. And we found CBD was really useful to help with this 2-week withdrawal period. So here's speculation and opinion, sort of wrapping up what we saw. Sleep, if nothing else, it helps people to ruminate less about their sleep. We're less convinced that it's an effective intervention. Social anxiety, we really do believe that it's helpful. Schizoaffective disorder, that has that social anxiety, that very sort of tremulous social interaction piece. We saw that with significant benefit. We're currently looking at trauma, PTSD, and thought disorder in our clinic currently in terms of CBD, and we have a sense that it's going to be helpful for PTSD. And public speaking, I think it's just a natural for that. I'm going to just tell you that I feel very calm up here today, but I'm not going to go to any more self-disclosure than that. Here's some of the things that we do at our clinic for anxiety: inositol, 5-HTP, relaxation, meditation, walking, yoga, journaling, Psychotherapy, EMDR if there's trauma, L-theanine, we love L-theanine. CBD, I think it's too early to recommend it. It's speculative, but I think we see potential. We're not a fan of caffeine and anxiety problems. We look at diet as well, and if they're obsessive, we look at using N-acetylcysteine. We find that very useful. So in summary, cannabis has a long tradition in the healing arts, and we know that the endocannabinoid system plays a central role in most biological systems, and we can take advantage of that. CBD as an intervention seems very well tolerated and seems to have a calming effect on the CNS. And CBD could really have, I think, a future in psychiatry, and we've become very fond of it in terms of our clinic at this point. So with that, do we have time for a couple questions? 2 questions. Yes? I don't know. He said he uses Charlotte Webb, and it's a cannabis product. I know it's a high CBD, low THC. We're not using any THC. So I think it's a little bit difficult to compare, but it's possibly close overall with that caveat that we have no THC. Yes?
This neutral CBD, decarboxylated CBD, do you know? Or it's CBD acid?
I don't know of that. In the back there.
I'm not sure where you're pointing.
Someone's coming up.
He's welcome to go. Here's a quick one.
Okay.
Just a quick question about any other information or research on CBDs and autism, and also the difference between vaping, eating, and smoking. And what you generally use.
CBD and autism, yes, we found it helpful. We probably had a segment of about probably 5 or 6 different patients with autism. We think it has a calming effect. We think it helps with their social anxiety. So yes, we have used it. Often the doses are small, 3, 6, 9 milligrams. And it comes in a spray, makes it easy to use. So we're a big fan of that. Question, vaping, smoking, eating. We tend to use oral capsules. It seems to be the most broadly accepted in our clinic population. A lot of them have been sort of culturally trained to take pills. So that seems to be the simplest. Some people do prefer the sprays, but I'd say the vast majority are using capsules.
With the, you mentioned a number of doses used in different studies. You said you found 25 milligrams to be good. Then this a couple studies had 600, 800 milligrams a day. Is there any with antipsychotics, 80% of the binding of D2 receptors is associated with decreased psychotic symptoms. Do you have any idea what dose, how much of FAAH is bound when you have 25 milligrams of CBD versus?
I don't have a sense of that. We do have a sense that for PTSD and thought disorder, the doses probably need to be significantly higher. We did not see much benefit in OCD, so we sort of stopped toying around with that. But for most of our patients with simple, uncomplicated anxiety, 50 milligrams or less was all that needed to happen. We're guessing 100 is our target for PTSD. And I guess if we're needing to wrap up.
We can take one more question.
One more question. Yes?
Have you used CBD at all in helping patients to get off of SSRIs after years and years of use?
I would say indirectly, yes. It's sort of one of the many different things we look at. But yes, because it has a calming effect on the CNS, it can be helpful. So people can come up, and I'm happy to dialogue with you here. We
Thank
have
you,
a break
Dr.
now.
Shannon. We have a break now for about half an hour, and if you're willing to stay, I'm sure there are lots of other people who want to ask you some questions.